session, so I would, without delay, if chairpersons allow me to proceed, I would like to go to the next talk. Next speaker is Dr. Radha Reddy Chada. I would like to invite her to give her talk. She is a lead clinical dietitian and head of department of clinical nutrition and dietetics at AIG Hospitals, Hyderabad. She has over 22 years of teaching experience in clinical nutrition, dietetics, community nutrition, and public health and food science. She has 10 years of clinical practice in hospital. She has assumed various leadership roles in teaching and training sessions, as well as has important publications in several renowned international journals. So I would like to invite Dr. Radha to give her talk and give some insights into nutritional assessment and enteral nutrition. Time is yours, ma'am.
You all can view it?
Yeah, Radha, we can view your screen.
Yes.
Yeah. Thank you so much for the kind words, Dr. Haim. And thank you for the whole team who's actually organized this meeting to share knowledge on what we perform or how we perform in terms of improving the nutritional conditions or provisions for patients who are hospitalized. So I've been there in this, let me tell you, it's a journey. It's not a one-day process that has happened to all of us who are in this area of nutrition. I kind of finished my MSc 30 years ago. And at that time, there was hardly anything which we were recognized to be doing in critical care. And now we have an area where it's a super specialty for the dietitians to perform. And so you have critical care dietitians who perform extensively into critical care nutrition. So this is something that as knowledge or as evidence has been improving in the areas of nutrition and critical care, that we have the scope of providing good nutritional care for patients who are hospitalized. And today I would give you a little introduction on how we do things and what are the best methods that you can follow to provide nutritional care for patients who are in the ICU. So this is about clinical nutrition practice in the current times, and I would be focusing on nutritional assessment and enteral nutrition. Okay, the learning objectives will be about most of it, some of it, or let's say a part of it has been covered by Dr. Dabhi. But yes, I will redo it a little again. And so we will be discussing a little about nutritional screening and assessment and how to differentiate between them. Because the guidelines say something and how to understand them and what do we do to differentiate both of them is important. And then what is the criteria for diagnosing malnutrition and how are they done generally? And then explain how to use nutritional assessment tools to monitor the nutritional status. That is something that we should know. And then to provide an overview of practice guidelines about enteral nutrition in critically ill patients. This is the workload generally that every dietitian should actually know it very, very, very well. Yeah, so it's called as the ADME, where you assess the patient, you diagnose whether there is malnutrition or not, then you intervene, and then you do monitoring, and then you do evaluation, and then the cycle keeps repeating. This is what is generally done for every patient that is admitted in the hospital. And more so, it applies very, very important for patients admitted in the ICU. So this is what is the whole process that happens in the patient journey in the hospital. The same thing, how do we go about when the patient is admitted? You get the patient screened. I will go more in detail on how to get it screened. And then you assess those patients who are not at risk. Then you just do periodic rescreening. But who are at risk, you do the assessment more detailed to find out whether there is a high risk or a low risk, or are they malnourished or severely malnourished, or they are well nourished. And then develop a nutritional care plan for them. Once you develop a care plan, it doesn't go there. It just doesn't, the work doesn't stop there. What is most important is implement. Implementation is where you have the other individuals who are involved in patient care help us in implementing the nutritional care plan. And then then once you implement, you should monitor what you've done is correct or not, what you've prescribed is being followed or not, and whether the patient is able to tolerate or not. That is most important. And if the monitoring is good and the goals have been achieved, then you stop therapy and then the patient is discharged, or you reassess and update your status. Reassessment can be done every day. Reassessment can be done once in a week, depends on the patient progress during the hospital stay. And then if you've implemented the monitoring and the monitoring is good, you continue the care and then you plan for discharge. Remember, this is one thing, that discharge planning is something you have to do ahead of time from the time of admission of the patient. So you should, as a professional, should have an idea of what you should be telling them at the time of discharge. So that is the expectation of the assessment, daily assessment or daily monitoring that you do with the patient. Coming to the first section, screening and assessment are fundamentally wrong, different, not wrong, sorry. The screening is just something which takes about a minute or two for evaluating and recognizing signs and symptoms for any nutritional problems that prevail in the patient. Then identify these patients who are at risk or having poor nutritional status, and then who require a detailed nutritional assessment. Okay, just by 2-3 questions, you won't know the full details about the patient's intake, patient's various symptoms, maybe gastrointestinal symptoms. There are so many other things about their mobility, about their biochemical parameters. So all these you have to know. Okay, and so then what is nutritional assessment, which is different from screening? Screening just tells you whether the patient needs an assessment or not, whether the patient is at risk for malnutrition or not, and so you go ahead. And then evaluate the clinical condition of the patient when it comes to an assessment. Okay, what are the symptoms that the patient has come to the hospital? And how are they at risk for developing malnutrition? What is their diet pattern that they have been following? Is it an oral diet? Was it a liquid diet? Was it nothing at all? Was it nil by mouth? Was it an enteral feeding? And what is their body composition, which is the latest guideline which says that you have to know the percentage or the composition in terms of, muscle mass and fat mass, and any biochemical parameters that are correlated with the condition or the diagnosis or the medical diagnosis that is made. Biochemical data can vary depending on who your patient is. And so, but you have to look at it and then classify the patient accordingly as being well nourished, moderately malnourished, or severely malnourished. There are various screening tools, all are freely accessible. You can use whichever is applicable to you or you feel comfortable, can fit into your organization, because most often what happens is you can tailor make your you can tailor make one of these tools to fit into your organizational requirements. But the basic questions are almost the same in each of these. They have been validated tools and you can use any one of them. It could be the Geriatric Nutrition Risk Index, Mini Nutritional Assessment, which has been widely used in the elderly, Malnutrition Screening Tool, which is a very short and most widely used screening tool, which has just 3 questions, and then you answer them. Any number more than 0, then you have to go in for an assessment. Then Malnutrition Universal Screening Tool, which is otherwise called as the MUST tool. This is generally used for community, but can be used for hospitalized patients too. And Nutritional Risk Screening, it is called as NRS 2002, more widely used and a better indicator of whether the patient is at risk for malnutrition or not. And what do all these screening tools probe into? Okay, generally they collect information on weight loss and appetite. Okay, they generally ask whether you've lost any weight. That is what we generally ask. So you just record it. Recording is more important. It's not that none of us ask these questions in our day-to-day review with the patient. But when you record, you know what is the prevalence in your own hospital. Once you go back to your data and then you kind of check onto your data, what is the prevalence of malnutrition or how many people have said that they did lose weight, then it is easily accessible. Then probably you're asking about inadequate oral intake. Were you eating correctly or not? Have you lost weight is a usual question that we ask. And we ask them how much they have lost and then categorize them as something more than 5% in 1 month's time or previously 1 month's time, or more than 10% between 3 to 6 months. And do they have the right appetite is something that we again ask. Are you able to eat? Do you feel like eating? There are different ways of asking the same question, but then these are the points that any screening tool will probe into. And then what do you do once you do the screening? Okay, say supposing you've taken MST, malnutrition screening tool, which talks about unintentional weight loss, poor appetite, and downward trend of serum albumin and BMI. These are things that you can actually see. And then you say whether the patient is at risk or not at risk. If not at risk, schedule for next routine screening. If at risk, then have a detailed nutritional assessment. This is something, it should be done routinely, and it should be a part of the nutritional team duty as they come in every day to see every new patient. And so it should be performed in all patients. This is what even Dr. Dabhi showed, but there are 2 sets of people who come to our hospitals. They could be the very underweight ones, they could be the overweight ones, but then they both are equally at risk for malnutrition when they're hospitalized, because it is not just about starvation related malnutrition, it is not disease related malnutrition, but it could be hospital related malnutrition too. So you need to know all these before you actually intervene with the patients. Then coming to the next aspect of nutritional evaluation, where it is nutritional assessment. There are various components which you can actually see in assessing nutritional assessment of the patient. It could be BMI, where you just take the height and weight and check. It could be waist circumference also. Of course, skin folds are a part of nutritional assessment, but then it's questionable because the latest guidelines do not talk about it. And then the latest guidelines do talk about the recent use of body composition as a tool for assessing nutritional status. That is the BIA, the bioelectrical impedance analysis, or you take the DEXA, which talks about the muscle mass, or you take the mid-arm circumference. Again, this is questionable because it doesn't talk about, in the latest guidelines, MRI and the CT scan. These are all things which can be used in terms of anthropometry and body composition. Yes, there are lab tests which can be linked to malnutrition, and some lab tests which do tell us a lot about the risk that the patient can be to develop nutritional or malnutrition itself. Okay, serum creatinine, albumin, pre-albumin, transferrin are questionable. Urea, total protein are some things that you can always see. But then albumin is not one thing which is questionable all across critical care, but it is a good indicator for the renal patients. So not always, that's the reason that I've put it here, that not always they are contraindicated or they're removed from guidelines, but you can use them as an indicator sometimes in certain specific group of patients. And then you do check their food records, have a 24-hour recall or develop a food frequency, which would add value to assessing their dietary intake. You do have ready prepared scores like SGA, Subjective Global Assessment, which will tell you the score so that you categorize the patient to well-nourished, moderately malnourished, or severely malnourished. And then you have the functional assessment where you take care with regards to the hand grip strength. This is really very, very important because you know whether the patient is able to have good muscle mass, muscle activity, and able to take in, which can be identified with the hand grip strength, or whether they are able to move comfortably with the gait speed or the physical activity. These are things that you can see. And then there is a physiological assessment, which is done by the protein kinetics that you can actually do, or calorimetry, which talks about energy. Protein kinetics tells about like, you take the 24-hour blood urea nitrogen, and then BUN, and then calculate what is the excretion, and then you do the back calculation and see whether the protein recommendation that you've done is correct or not. And of course, calorimetry tells you about how much you're spending, and so how much can you actually recommend as total energy. And what do the latest guideline tell you about? The latest guideline tells you about, tells you about not to use markers, which I've already finished, not to use markers like albumin, pre-albumin, transferrin, but then you do evaluate their comorbid conditions, their function of the gastrointestinal tract. Do they have vomiting? Do they have loss of appetite? Do they have diarrhea? These are things that you should see, because that is something that kind of reduces their nutritional status. Or do they have a risk of aspiration? This is something that you should see. So these are things which you have to assess to know what kind of intervention that you can provide to patients. Avoid using protein markers, selective anthropometries like mid-upper arm, to, skin fold, all these, but you can use height. Of course, Dr. Dabhi did tell you about what is adjusted body weight, what is usual body weight, ideal body weight, and what is BMI. These are things that you can do. Look into the markers of inflammation or infection, which can give you an indication of the disease-related malnutrition. Okay, then look into assessment. There are latest assessment tools which says that you do have what is called as the dietitian's physical examination. Nutrition-focused physical examination is something that tells you about muscle mass. How much is the risk for the patient? So you look at each of these different areas, look at the temples, look at the clavicles. These are the areas where you can look at for muscle loss among the patients who are admitted in the hospital. Then there is a CT scan where you have a cross-sectional imaging, which will tell you about the muscle composition. And this is the guideline which generally talks about what do you do. There are various guidelines. Let me go back to, okay, sorry. Yeah, there are various guidelines which will come further in my slides, which talk about when do you feed. Once you know that there is nutrition screening, when do you do? What are the methods, tools that you can use to do the nutritional assessment? Look into all these guidelines which are there. We do have Indian critical care guidelines too. We do have European guidelines. We do have American guidelines for all these, and they're freely accessible. Just look at them and then try to see whether you can actually utilize them to develop protocols of nutrition intervention, screening, assessment, intervention for critically ill patients. And then the regular methods of nutritional screening and assessment are there, but the latest guideline also talks about something which is called as nutritional risk assessment. It's not just about the regular, but you have to also know what is the level of risk for mortality among these patients. Risk of malnutrition during hospitalization and risk of mortality during hospitalization is something that you will know from patients who are admitted. So that is called as the Nutric score. The guideline, the ASPEN and of course the ISPEN also talk about this guideline, which says that patients with low disease severity, which means that the NRS 2002 score should be less than 3 and the Nutric score should be less than 5 to call them as low nutrition risk. Anything which is more than 3 for NRS 2002 and then anything which is more than 5 for Nutric score, then you call them as high risk patients who are admitted. And so this is what is the modified Nutric score, because traditionally the Nutric score had IL-6 values, but then since it's an expensive test to be conducted for all patients, they removed and gave us a score without the IL-6 value. So this is what it's Dr. Darren Haaland who actually brought out this score and said that you can assess patients to know what is their risk of developing malnutrition or risk of mortality during hospitalization. We did one study which we published that paper too some time ago, presented this paper at the PENSA conference in 2018, published the paper where we linked the nutritional assessment intervention of hospitalized patients with 28-day mortality. So that means we followed these patients for 28 days during and after discharge, during hospitalization and after discharge too, to know what is the level of mortality among these patients, and of course looked into the monitoring of feeding among these patients, all ICU patients, and then linked them. And of course, I just showed you this, that you can categorize your patients into low risk and high risk and then connect them to the length of hospital stay, length of ICU stay. All these are very interesting that you can do in the hospital, and it is led by a dietitian. And then what do you do? Once you know that your patient is malnourished, what do you do? How do you do? How does it work for you? So this is something that you should know. When you know that you've screened the patient, then you assess by SGA most often, which is the most widely used tool. And then you decide on the nutritional intervention. How do you decide? You decide on how much. So you must know what are the nutritional goals. And then you say how. Is it oral? Is it enteral? Or is it parenteral? And then what is the access? Whether it is, for enteral, there are different access methods. For parenteral, there are different access methods, which Daphnee will do it for you. And timing. So when do you start feeding? When do you start providing food to the patient? And what do you do? What is the formula that you select? Once you've decided on that, then you start your intervention, but monitoring becomes most important. Then supervene, then plan for discharge. So this is what is the whole cycle of trying to do intervention for the patients. So this is what generally we find is patients who are critically ill are most often suboptimally fed. This is a general finding that we see. And why do you think that they are suboptimally fed? Because there is less consensus of all these aspects. Which is the preferred route of feeding? You take time to decide. And so you are delaying the feeding. To which patient should nutritional support be offered? For all. But then we still want to take a decision on that, because there is always a confusion. And how much to give each one of them? What are the targets that you have to meet? What is the ideal composition of a feed? How much of carbohydrates, how much of protein should you be targeting? What is the fat content of this? So how much of calories itself that you have to know? And then when do you start? Most often you don't start. The recent study which we did and published, we actually want that we kind of saw that, and then why is it necessary to feed them? And then we actually linked the 28-hour mortality to the amount of calories that is provided to the patient. The more the deficit, the greater was the mortality. So, this is the link that we can create too. So nutrition is the first intervention that has to be focused on to improve patient outcomes. And how do we decide? We come into the next section on parenteral is something that Daphnee will do, enteral is something that I will do, and so I've come into the enteral nutrition aspect of nutritional intervention. So how do you go about this decision making? What do you do? First, you have to know that if the intensivist has told us that you can start nutritional support, which most often should be done within 24 to 48 hours. And so then you decide, does the patient have a functional gut? If yes, start off with enteral nutrition. When you know that the oral intake is not satisfactory, or when the patient cannot swallow, or the GI is not functional, then you think about parenteral nutrition. And then the patient failed to recognize with oral intake, then you think about enteral nutrition. And then say you have some kind of obstruction, then you think of enteral nutrition. You have some motility problems of the gut, then you think of enteral nutrition. So these are things which tells us about indications on when to start enteral nutrition. And you should also decide on whether enteral nutrition is for short term or long term, because the axis is something that decides on whether it is short term or long term. Does the patient have any stomas? Does the patient have any tubes? Because all these are the things that you should know before you intervene the patient with enteral nutrition. These are the guidelines which generally guide us to deciding what we have to provide to the patients, where we have to provide, how much we have to provide, when we have to provide. So all these questions are answered by these guidelines. These are the indications that you generally have to follow for different methods of enteral nutrition that is done for patients. So all these conditions, whether you have indications, whether you have contraindication. When there is a contraindication, it means that you should not delay, but then start with parenteral nutrition. Of course, there is a guideline for that, and then I'm sure Daphnee will do when to start parenteral nutrition. So Daphnee will do that for you all, and I'm not getting into that. This is the area where you should know. These are the different modes of enteral feeding that you can do. Routes of feeding. You have from the nose to the gut, to the stomach. It's called as nasogastric tube. You have from the mouth to the stomach, it's called orogastric feeding. Then you have from the nose to the jejunum, it is called nasojejunal feeding. When you have it from directly by a percutaneous method into the stomach, okay, endoscopically it is placed, it's called as a PEG, or percutaneously endoscopic gastrostomy tube, it's called as PEG. Or you have a PEG, which is directly into the jejunum, it's called as feeding jejunostomy. Or you have an endoscopy method of inserting direct into the jejunum. So, of course, the first line of treatment is oral diet, but then you can get into enteral nutrition when you know that you're not able to feed the patient orally, or it is not sufficient. There is a guideline which talks about that, which we would be doing. So once you know that the tube is placed, then you start thinking about what to do. You have to feed the patient within 24 to 48 hours. These are the guidelines which tell us. And then you have to look out, of course, the first is look out for observations of malnutrition. It could be cachexia, it could be edema, it could be muscle atrophy. What is the BMI? Is it less than 20 kilograms per meter square? Okay, all these are important to indicate, and then you immediately start within 24 to 48 hours. And then is considered when do you do enteral feeding on a normal patient, but when the oral intake is not able to meet at least 50% of the requirements, then you can do that. But when you have to wait for at least a few days before you can decide on starting enteral nutrition, apart from the general indications for enteral nutrition. When you are not able to meet the enteral requirement for more than 72 or 7 days, then you think of parenteral nutrition. Okay, so that is what is the decision-making tree that you all have to follow, which is there very clearly pasted in the guidelines, which is very easy to implement in the ICUs. And then you come into a patient who is hemodynamically not stable. How do you go about feeding them? Once the patient has been fluid resuscitated, that means the fluid status has been more stable, and the vasopressors that are used for the patient to stabilize are less than 2. Okay, then you can start enteral nutrition. When you know that the gut is functioning, then you can start enteral nutrition for a hemodynamically stable patient. And then, of course, you should know that you should start off within 24 to 48 hours once the patient is stable with vasopressors. In persistent shock, we do not feed the patient, but wait for the shock to subside, and then you feed the patient. And then these are the different kinds. What are the kinds of tubes that you can use? What is the size of the tube that you can use? These are things which generally are taken into consideration when feeding the patient. But in a patient, when you are feeding, but the patient is having some kind of, a contraindication or not absorbing, say supposing the patient has diarrhea or abdominal distension, then you have to think about using a prokinetic. This is a medication where you give for the peristaltic movement to happen, and then you continue to feed. Or you decide when the patient is on gastric feeding, whether you should think of jejunal feeding. So the jejunal feeding is very rare, but then it is the best to prevent any aspiration to happen. And if there is poor gut motility, then jejunal feeding becomes a next line of treatment. What is most important is hygienic preparation of the tube feeds that are being provided to the patients. What to feed? So you have to, now that you know how to feed, when to start a feed, where to feed, now you should know the formula that you want to feed. Okay, so you have to select a particular formula, and there are various reasons on what you should consider to select a formula. What is the functional status of the gut? That is something that you should know. So that will tell you about the volume that you can actually feed. Then what are the pre-existing conditions? Is the patient having a renal condition? Is the patient has the patient come to you in trauma? Is the patient having a liver condition? So all these are things that will indicate what is the pre-existing conditions. What is the renal parameters? What are the electrolyte parameters? All these. What is the LFT parameters? All these you should know. Any metabolic needs? Say supposing very high metabolic needs will be like somebody who's come to the hospital with burns. So then what do you do? Any specific nutrition needs in terms of, say you have a patient who's pregnant. Then what about a child? What about pediatric patients? These are all individual specific populations what about the elderly? So all these have to be taken into consideration. What is the physiological characteristics of the formula? Okay, what is the osmolarity? Does it have fiber? What is the calorie density? What is the viscosity that you would look into? So all these are things that you should see, which is given on the container, where you compare and then see what is the best that you can give for somebody who's in this. So like, for example, you have a patient who's uncontrolled, who comes with diabetic ketoacidosis. Then what do you do? After the patient has been corrected for acidosis, do you give a high fiber feeding, or do you give a regular feeding is something that you should see. So what is the carbohydrate content that you would see? Micronutrient ratios. Do you give the typical 60% carbohydrates, or do you reduce it to 45% carbohydrates in a diabetic patient? What is the macronutrient composition for a renal patient, in a liver patient? So all these are things that you have to monitor. You have to know from the formula. Then what is the amount of fluid that is given to you? What is the electrolyte requirements? Is there any restrictions? So these are things. So these formulas are, you have 1 ml 1 kilocalorie, you have 1 ml 2 kilocalories. So you have the calorie dense and the normal calorie products. So you have to know what you want to meet too. And most importantly, what is the costs? Are you able to satisfy the cost? And will you get the outcome with the cost that you are spending for nutrition? These are the guidelines which actually tell you, and what is most important is this, that the different kinds of, you have the polymeric feed, you have the oligomeric feed, you have disease-specific feeds, you have modular feeds. These are different kinds of products that you can actually use for patients who are critically ill. But what is most important is it should be evidence-based nutrition intervention. What is the evidence for any decision that you take? How do you go about? Who is your patient population? What are you looking at? What is the outcome that you're aiming at? All these you should know. What are your end points that you're looking at? And then select the particular formula. But what is most important at this point of time is, yes, we do have this practice that is on, that enteral nutrition is always done with kitchen-based blenderized feeds. This has been there a very long time. Let me tell you, I have been into this era of where we were trained to give kitchen feeds for enteral feeds, way back 30 years ago. But then now is the time when we give 100% scientific feeds, scientific formulas. So there are guidelines which says that blenderized kitchen tube feeds that is prepared in the kitchen are not really very advisable, because there is always a risk for contamination. There is always an inconsistency for nutrition composition, because it's a diluted product that you want to give that can pass through the tube. And then there is always this problem of viscosity, problem of osmolarity, problem of the tube blockage with kitchen feeds. So all these are things that you should really see. You look at the risk and the benefits that you want from kitchen feeds, from scientific formula, and then decide what is it that you actually want to feed the patient on. And then we generally use a standard polymeric feed formula for all patients across the populations in ICU. You can see the calorie density, but then a standard polymeric formula can be used. Inconsistency can be avoided because standard polymeric formulas are made with keeping the patient population in mind. And then routine use of specific formulas are generally avoided, and you can meet them with feeds, polymeric feeds. Then what is the calorie calculations that you want to do? It is 25 to 30 kilocalories per kg body weight is the recommendation. Protein is around 1.2 to 2 grams, depending on who your patient is. And then maintain a nitrogen to calorie ratio to 120:1 or 100:1 at least. And then for burns patients, for calculating the energy, the Toronto formula is the best method that you can actually use. And once you know that you have started intervention, you know that you've kind of fed the patient correctly, and but you have to know the adequacy. Are you able to meet the requirements, whatever the nutrition goals? Okay, so that is what is hypocaloric nutrition, which is less than 70% or less than 80% or less than 70% is not really advisable. But the initial acute phase, yes. but later by day 3, you should be able to satisfy 80 to 100% of the recommended nutrition goals. This is a paper that we presented with AICNU way back in 2016, where we did say what is the benefit with length of stay with adequacy of nutrition through enteral feeds among ICU patients. And most importantly, it's not just about macronutrients. The micronutrients do play a role. How are you identifying whether they have been given the right quantities of micronutrients? Because any deficiencies that need to be corrected have to be corrected. Supplementation is important. If it is blenderized kitchen feeds, it's a difficulty to meet the micronutrient requirements, so supplement becomes important. But you have to know what is the pre-existing deficiency. So our baseline values, whether it is minerals, whether it is vitamins, you have to know what is the baseline micronutrients to provide supplementation. Something like trace elements like zinc and selenium, trace, vitamins, B-complex vitamins, especially thiamine, where you are giving energy, but then they are deficient. So whether you can give a micronutrient. When you're giving a scientific formula, most often all these micronutrients are a part of the formula. But then extra supplementation is required when the patient is at having a pre-existing deficiency or at risk for refeeding syndrome or on parenteral nutrition. And then documentation is most essential that you should be doing once you intervene. Okay, whatever, the daily basis. On a daily basis, you assess, you see what is your nutrition care plan, then you write it down, and then you look at what you've done yesterday and then see what you can do today. And then you record it, because it may not be you the next day. So the next person or anybody as part of the nutrition support team should be able to understand what you're trying to give the patient or treat the patient with. And so documentation becomes very easy, very important for you to do. Monitoring tolerance and adequacy. GRV is one common thing that you have to know. Gastric residual volume, do you feed or not? Do you stop? Are prokinetics being given? Is the patient having abdominal distension? Is the patient having, diarrhea? Is the patient having vomiting? All these are things that you have to look into monitoring and then meet the adequacy of nutritional feeding. There are guidelines which say holding enteral nutrition for GRV less than 500 ml in the absence of intolerance should be avoided. So you continue to feed. Probably in some places, yes, you reduce the volume of feed, but then continue to feed. Anything which is more than 500 ml can be a cutoff, at least in the Indian scenario, to stop or withhold feeds. So there are different scenarios. You have to develop your own protocol on when to feed, when to continue, when to stop, all this. And then you can always do the day-to-day monitoring and change accordingly as per your protocol. This is an intensive care unit protocol, which is there, which is easily downloadable, which is as part of the Indian critical care guidelines that have been given, which will tell you on how to go about the decision-making tree, when to reduce the feed, when to increase, when to keep meeting the requirements, how to progress into improving the adequacy of feeds. All this it will tell you. And that's it about my presentation. Thank you.
Thank you, Dr. Radha, for your